introduce Dr. Brienne Miner, who's assistant professor in geriatrics from Yale University. Dr. Miner is a geriatrician and sleep medicine physician and researcher interested in improving the management of sleep-wake symptoms in older adults. After receiving her MD from the State University of New York Downstate Medical Center, she completed further training at Yale University, including residency in internal medicine, a clinical and research fellowship in geriatrics, and a clinical fellowship in sleep medicine. Her current interests include evaluation of sleep deficiency in older persons using self-reported and objective measures. Ultimately, she aims to design interventions for sleep deficiency in older persons with and without cognitive impairment, which may lead to improvements in cognitive and physical function. So I think we all agree this is such a huge issue and problem. So we're very excited to have you here today. So thank you.
Okay, thank you for having me. So this is the title of my talk, and I don't have any conflicts. And I wanted to just go through an outline. I'll show you guys this thing because I saw this at Disney World. I thought it was so funny and appropriate. An informative lecture, How to Sleep, presented by educator and somnambulist, sleepwalker, Goofy. It says, guaranteed by the time this lecture is over, you'll be fast asleep. So obviously I'm hoping that you're not going to be fast asleep, but I am hoping to teach those of you who don't already know, and I can see some of you already know a whole lot about sleep, but I do want to have in this talk some teaching. I hope there's some trainees out there who are sort of trying to find their path, maybe in medicine and research. So I'll talk a little bit about how I came to my path. I'll have a case that I hope is sort of illustrative in terms of why I do what I do. We'll talk about some basic concepts of sleep and unique aspects, I think, in older people. And then I'll talk about sleep deficiency, what I mean by that, and future directions for my work. So this is my trajectory. Here I am in 2009. That's when I first came to Yale, and I've been here ever since. So I was an intern. I was doing a pulmonary elective. And so I finished my internal medicine training, and then this is me during chief year. So we wore slightly different masks at this time. This is our masquerade ball that we give for the residents in the doldrums of February. And so, you know, because I had this training, I've always loved teaching. And so I hope that I can do some of that today, besides boring you with all of my research. So hopefully none of it will be boring. So now this is a little bit more recent. These are all the amazing people in geriatrics that I get to work with every day. So I did, as Dr. Bradley mentioned, I did a clinical fellowship, and then I did a research fellowship in geriatrics. And it was during my research fellowship that I studied dyspnea, shortness of breath. And that project really introduced me to thinking about symptoms in older people, and, you know, really trying to think of them as a multifactorial geriatric health condition. So with multiple domains affected, because older people usually have multiple things going on. And so with that project, I looked, you know, I kind of went beyond cardiorespiratory impairments to think about what other impairments in other domains, things like muscle function and neuropsychiatric impairments, how those might also contribute to dyspnea. But while I was doing my research fellowship, I was working in our geriatric clinic. So that's the Adler Clinic, and this is a statue that we have outside of our clinic. And here is what I'm showing, you know, what I'm showing you guys is probably well known to most of you. This is the mission of geriatrics. Really, we want to improve the health, the quality of life, and the independence of older people. And so when I'm in this clinic, this is my mission, and I'm trying to accomplish this among a group of people with many medical conditions, many geriatric impairments. And, you know, so it can be a complex, a population with a lot of complexities. And so this is where I really got interested in sleep. And so what I'm showing you here is the prevalence of sleep problems and how it increases with multimorbidity. So we have here on the x-axis the number of chronic conditions, and then the prevalence on the y-axis. And what you see is as the number of conditions increases, the prevalence of reporting a sleep problem also increases. So for those people with greater than 3 chronic conditions, almost 70% of them report a sleep problem. So here I am in this geriatric clinic, and there are just so many sleep problems. The other issue with this is these sleep problems are kind of counter to the mission of geriatrics. They are associated with falls, with impairments in basic activities of daily living, hospitalization, depression, cognitive impairment, and even institutionalization. And so here I am with these patients and their families, and they sort of want to do everything they can oftentimes to keep my patients in the community, to keep them at home. And so I saw sleep as a major problem here and something that I wanted to help with. The problem is I didn't know what to do in these people with very, very complex histories. I knew what I wasn't supposed to do. And so what I'm showing all of you here, many of you know about the Beers criteria. This is potentially inappropriate medication use in older adults. And pretty much any medication we would use for sleep is on the Beers list, right? We've got our benzodiazepines, we've got our benzodiazepine-like medications, our Z drugs, and then the Beers criteria also tell us, not to use amitriptyline, doxepin in higher doses, or antihistamines. And so I felt like I needed more training to figure out how to help these people. And so I did a sleep fellowship. I'm showing you here, this is Carlos Fergoso. He was my primary mentor until retiring, and always gave me really great advice, both for my career and my personal life. But he was the one who really convinced me I should do a sleep fellowship. So, I spent a year working with all these people, and, I thought I was doing it to try and figure out how to treat these people in my geriatric clinic. But it is just such a fascinating field. And I couldn't believe all the things that I learned, and what a great field this is with so much exciting stuff going on. So it was really a great decision. And I got to work with some other people. So now I'm showing you Tom Gill, who's my primary mentor in geriatrics and aging. And I also work with Clara Yagi and Melissa Knauert, who are both pulmonary critical care and sleep medicine doctors here at Yale. So that's my trajectory. And now I want to move on to this case. And so I will tell you, this is an actual patient that I saw in my geriatric assessment clinic. And I will also tell you, I guess, two other things. This is illustrative. This is a common experience for me. And I will tell you that this woman did not come to see me because of a sleep problem. So this lady was a 79-year-old woman who presented for a medication review after relocating from Florida to live with her daughter in Connecticut. And so she was accompanied by her daughter to the visit. She'd been widowed for 3 years. She had recent episodes of confusion, poor appetite, delusional thoughts. She had been declining in terms of her function. She was getting lost while she was driving. She fell victim to financial scams, and she was responsible for her medication administration. But it was clear that wasn't working well. She wasn't refilling her meds, and it was kind of like nobody knew what she was really taking. She was depressed, and she was socially isolated. I know this probably sounds pretty familiar to those geriatricians in the audience. So past medical history, in addition to depression and diabetes, she had hypertension, hypothyroidism, and had already been diagnosed with mild dementia. And here's her medication list. And this is like something you can't make up. So in addition to some cardiac medications and a thyroid medication, she's just on a whole lot of psychoactive medications. Aripiprazole, bupropion, buspirone, donepezil, duloxetine, sertraline, and solifenacin. And as a reminder, solifenacin, it's Vesicare. It's a medication that is used for bladder spasm, but it is anticholinergic. And so it is a medication we like to try and avoid in older adults, especially those who have cognitive impairment. And so I am a sleep doctor, and I'm often asking my patients about this, which is why I asked this lady about her sleep. And she told me she sleeps pretty well. She feels refreshed during the day. She wants to increase the solifenacin due to frequent urination at night. She sleeps in a recliner, and her daughter reported that the patient snores. This is her sleep schedule. So she sleeps from 10:30 at night until 8 o'clock in the morning. Her latency is, quote, not long. She awakens 3 to 4 times a night to urinate, but goes back to sleep easily. And she naps, she thinks maybe about 2 days a week for 30 minutes. I often use a couple different validated questionnaires in my practice. And so what I'm showing you now are some questionnaires that I use: the Insomnia Severity Index and the Epworth Sleepiness Scale Score. I'm going to talk about these a little bit more in a couple slides, but to suffice it to say that her scores were very much in the normal range on these questionnaires. And so now I want to ask a question of people, which is, would you get a sleep study for this patient? And so maybe, I don't know, raise your hand if you think this lady should get a sleep study. One raised hand. Other people are, maybe they have their 2 raised hands. Okay, so I would say, you know, it's not like there's a clear right answer here. I decided to get a sleep study on this patient, and I'm going to tell you why. So first of all, I'm pointing to this medication, but the fact is she was on a lot of psychoactive medication. She clearly had significant psychiatric disease. And, you know, so I am concerned about people's ability to really accurately report symptoms in the setting of being on so many psychoactive medications. I should also mention that, you know, this feeling that she had frequent urination, especially at night, for those people who know about sleep, you know, I'm sure this is setting off alarm bells in your head. The fact is, frequent urination that happens especially at night is often a symptom of untreated sleep apnea. The daughter, and this is where collateral history becomes so important, always in geriatrics, and I think it's especially important when we are taking sleep histories. The daughter sort of reported that maybe things were a little bit different than what the patient was telling us. I see Dr. Z is saying, why does she sleep in a recliner? OSA high on the list. Yeah, absolutely. So I do think that's something I ask about a lot because of my sleep training. I ask patients about the sleep environment. And so when it comes up that they're sleeping in a recliner, I am also often thinking of sleep apnea, because if you sleep in a recliner, your head is elevated, you're less likely to obstruct your airway. So it's almost something that people kind of, it's a way that they're self-treating, is by moving from the bed to the recliner. So then the next thing is her bedtime. This lady's actually sleeping for a very long time, right? So 11.5 hours. As I mentioned, she's urinating multiple times a night. Oops. And then, yeah, so here's the test that I often get in these people, which is a home sleep apnea test. And I'm going to talk about this in a few slides, but I'll just highlight what we found on hers. So first of all, here's her saturation during the night. And you can see she has these 2 dense points of deep desaturation throughout the night. And if we look down here, we can see the respiratory events that are happening coinciding with these desaturations. And you can see that she's having a lot of apnea. So hypopnea is a reduction of airway flow, and apnea is an almost complete cessation of airway flow. So she's having a lot of obstructive apneas. Here's a kind of a zoom in to her sleep study, and this is a 5-minute window. And so here we're looking at the flow, and we can see that she's having these apneas, some of them pretty long, 18 seconds, 15 seconds. So cessation of flow, and then she's able to open her airway again, which is when we see that snoring. And then another cessation of flow opens the airway, more snoring. Then we can also, we have a thoracic belt that is looking at respiratory effort. So If she is having respiratory effort during these events, that's suggestive of obstructive as opposed to central apneas. And then we can see her SATs. So you can see that with each of these events, she's dropping her SATs. So overall, this study showed severe obstructive sleep apnea on the average of 40 respiratory events per hour with a nadir saturation of 77%. So, you know, given everything that I've told you, I think one of the things that I've been working on is to try and figure out what is the best way to assess sleep in older adults when we have cases like this where, you know, what they're reporting versus what we see on objective testing is so different, so discordant. And so, you know, while I've tried to get at that with some of my research, I wanted to spend a few minutes for those people who maybe know a little bit less about sleep in the audience to talk about basic concepts of sleep and some unique aspects of sleep in older adults. So first, I want to introduce you to this model that I think is just a really nice way to think about why we sleep. So this is the two-process model where we have the two processes being circadian and homeostatic regulation of sleep. So let's start with, why are we awake during the day? Well, in the first part of the day, we are awake because we slept at night. So here we are, we slept at night. Our homeostatic drive, which is shown by this top curve, these gray arrows, our homeostatic drive is low. In the second part of the day or into the evening, we're awake because our circadian alertness is high and it's opposing that sleep load, right? So homeostatic drive has increased, but our circadian alerting signal has increased to kind of oppose that homeostatic drive. So why do we sleep? Well, in the first part of the night, we sleep because we've been awake all day. And so that homeostatic drive is really pushing us to fall asleep. And in the second part of the night, we sleep because the circadian alertness is low. So we've started to dissipate our homeostatic drive, but the circadian alerting signal has decreased. So that's how we sleep. What about why we sleep? And this is, I think, one of the areas of research that is so interesting. There's a lot of really new developments going on because there's still a whole lot that we don't know about sleep. But what we do know is that sleep is important for control of hormone secretion and metabolic regulation. It's important for immune function, for energy conservation, particularly in the brain, for replenishment of brain macromolecules, for removal of neurotoxic waste. And so we're learning more and more every day about the lymphatic system, which is sort of like the lymph system of the brain. And it is thought that this is particularly active during slow wave sleep, and that system is what's responsible for removal of neurotoxic waste. Sleep is important for cognitive function and memory consolidation, for brain plasticity, synaptogenesis and recovery, and for physical performance. So here's some sleep architecture. And so what we do by convention, this is a sleep histogram. We have time along the x-axis here, and then we have the different stages of sleep. So by convention, we show wake at the top, and then REM sleep, which is rapid eye movement or dream sleep. And then we have first the lighter stages, non-REM stage 1 and stage 2. And then down here at the bottom is non-REM stage 3, may also be referred to as slow wave sleep. And that's sort of our deep and physically restorative sleep. So we start in wake and we fall asleep, and we go into first lighter and then deeper stages of sleep. And then usually about 90 minutes into sleep, we have our first REM episode. And then we'll cycle again. And then oftentimes REM might be ended by an arousal or an awakening that it's usually brief, and then we'll cycle through again. And so you can see in the beginning of the night, we have most of our deep sleep. And towards the end of the night, we're really cycling between REM sleep, where we're having more, dense periods of REM alternating with lighter sleep. But this sleep architecture does change with age. And so if we compare here with the arrows, a younger child, maybe a 7 or 8-year-old, the time they're spending in their REM or their slow wave sleep is much more than an older adult. You can see the time in REM and slow wave sleep is reduced. And so older adults tend to spend more time in stage 1 and stage 2. So if we think of the sleep architecture in a younger adult, which is sort of what I showed you, this sort of nice cycling through the different stages, what an older adult's sleep architecture might look like, and we think this is a normal part of aging, is that architecture becomes more disrupted. So there are more arousals and awakenings as we age, and that sort of leads to spending more time in lighter stages of sleep and less time in deeper sleep. So here are the National Sleep Foundation's recommendations for how much sleep we should be getting. And so you can see at this point in life, our newborns, our toddlers need a whole lot of sleep. But what some people might be surprised to see is that when we get to older adults, 65 and older, the sweet spot is 7 to 8 hours. Recognizing that 5 or 6 hours on one end or 9 hours on the other may be appropriate. And that's because older adults who sleep 7 to 8 hours tend to report better cognition, better physical health, and better mental health. So another thing that is a normal change of our sleep with age is, changes to our circadian rhythm. And so the first one that I want to talk about is a phase advance. And so in our older adults, we may see a tendency to go to bed earlier and get up earlier. And this is not thought to be pathologic. And the reason behind this, what I'm showing you is melatonin concentration. So in blue, we have what we would think of as a more kind of normal change in melatonin. So around 8 p.m., we have our dim light melatonin onset, melatonin increases, and that's sort of a signal to shut everything down, to go to sleep. So for older adults, they may have a more of a tendency to have this advanced sleep phase. So their melatonin concentration actually goes up earlier and comes down earlier. And so what we may see then is an earlier bedtime, maybe around 7:30, but also earlier wake time, maybe, unfortunately for some of them, 3 o'clock in the morning. Again, it's not pathologic as long as they're getting a normal amount of sleep, but we often hear about this because, most people don't like to be awake at 3 o'clock in the morning. The other thing we know about circadian rhythm with age is that there's a decreased amplitude of the sleep-wake rhythm, of the body temperature, of many different hormones. And so what that means is there's sort of a difference between the peak of the concentration of the hormones, or the peak of the activity, and the trough. So in taking a sleep history, what I will tell you is that, when you're with a sleep doctor, we're going to ask a lot of different symptoms that try to get at different disorders. And so that's what this laundry list is. But I want people who maybe are not sleep physicians and are thinking about, how do I evaluate my patient with sleep problems, to focus on the sleep-wake history and to get very specific about bedtime. So, I ask, what time do people go to bed and when do they get out of bed for good? And then you want to find out what happens in between. How long is it taking them to fall asleep? How many awakenings are they having? How long are they? In older adults especially, I ask a lot about napping, and then what the overall sleep duration is. Because if we think about the person who maybe has an advanced circadian phase, they may be complaining of that 3 o'clock wake up, but when we take a good history, we can see that they're actually sleeping for a normal amount, and therefore not do something like prescribe them a hypnotic. So I mentioned these before, these validated instruments that I like to use in my work. So the Insomnia Severity Index, here it is. And so up here, we're really asking about insomnia symptoms, difficulty falling asleep, staying asleep, or waking up too early. And then down here, we're asking about questions that really help to map onto a DSM diagnosis of insomnia, because these are trying to get at whether there's daytime dysfunction related to the insomnia. So you can see we ask, are people, how satisfied are they with their sleep? Is it noticeable to other people? Are they worried about it? Does it interfere with their daily functioning? And so this is scored 0 to 28. higher scores are more severe. And really the cutoff for what we consider to be abnormal on this is 8 and above. And then from there, we can see a mild severity would be 8 to 14, moderate is 15 to 21, and severe is 22 to 28. This is the other one that's probably the most commonly used measure to look at daytime sleepiness or hypersomnia. This is the Epworth Sleepiness Scale. And so we're asking people to rate their chances of dozing or falling asleep in different situations, sitting and reading, watching TV, and even in a car while driving. And so the range of this is 0 to 24. Again, higher scores are more severe. And then, sorry, my mouse is a little touchy. What we consider to be abnormal, the threshold here is 10, with 10 to 15 being a moderate severity of hypersomnia and 16 to 24 being severe hypersomnia. Okay, so what are the tools we're going to use objectively? Well, here's polysomnography, which is really the gold standard for objective sleep evaluation. And it's the gold standard because we're using EEG. We're looking at brain waves to see if people are awake or if they're sleeping and what different stages they're in. So it's the gold standard. We get a lot of information, but as you can see, it can be quite cumbersome for people to do. Also, they're sleeping in a sleep lab. And so we're not getting a really ecologically valid look at their sleep necessarily, and it can be expensive. But just to sort of focus in on what we're actually looking at, again, we have EEG and we have eye movements and chin tone to tell us the presence and stage of sleep. We look at EKG, we look at airflow to see if they're having apneas or hypopneas, and if there's respiratory effort associated with that. We have pulse oximetry, and then we also have EMG of the legs to look at leg movements. An alternative is the home sleep apnea test, which I focus to say sleep apnea because it's really all we're evaluating. But minus the mask, you can see an example of what patients have to do with the home sleep apnea test, and it's much easier. So, it's a pretty good test for sleep apnea. What we do worry about is false negatives. And so sometimes we might want to go on to do the in-lab study to have the gold standard test. And part of the reason is because you can see we don't have EEG, so we can't tell if people are sleeping. We also don't have leg movements. So that's sort of the difference between the polysomnogram and the home sleep apnea test. One other tool I want to mention that we'll come back to a little bit later is actigraphy, which is a well-validated objective estimate of habitual sleep patterns. So we're really looking at movement and using that to estimate when people are sleeping. And so you can see, you get a nice snapshot of what's going on over a week, right? You can see what their habitual sleep pattern looks like. And it's much easier. Most of the time we do it with a watch that they wear on their wrist. So very non-invasive, easier, much cheaper to do, and well-validated against the gold standard polysomnography. So those are some tools that we use in sleep and that I'm using in my research. And so now I want to talk about what I mean by sleep deficiency. So sleep deficiency, as defined really by the National Institutes of Health, is a condition that occurs due to poor sleep quality, which might be a sleep disorder like sleep apnea, insufficient sleep, or inappropriate sleep timing, which is to say sleep that is out of sync with the body's natural clock. And that a deficit in one of these domains leads to an impairment in daytime function. So I really like this definition because you can see we're identifying different domains in which a sleep deficit can occur. And I like this idea of domains in a geriatric population because in older people, they often have multiple things going on at once. So to try and think of things comprehensively and in terms of domains, I think it's very helpful in an older population. So I want to talk a little bit about the work that I've been doing to sort of define sleep deficiency in older people. And I'll start with that domain of poor sleep quality with some work that I did with insomnia. So this is work that I did with Tom Gill's Precipitating Events Project, which is a cohort study based here in New Haven. And these are community dwelling people, 70 years and above. They have these very nicely detailed home-based assessments every 18 months where we look at cognition and physical function. And, about 90 months into the study that is still ongoing, we started to collect the Insomnia Severity Index. And so the objectives of this study were to describe the epidemiology of insomnia and to examine the effect of age on ISI scores. Our hypothesis was that ISI scores will be higher with increasing age. And that's because we think in older people, they have multiple reasons to have insomnia. So they have those changes in sleep architecture that I mentioned that might make them vulnerable. They have health conditions that could impair their sleep in many different ways, including through, symptoms that might disrupt their sleep. There are psychosocial and behavioral factors, things like caregiving, substance use, bereavement, social isolation, problems with physical function that might impact their sleep. And this is a population with polypharmacy, and medications can affect sleep in many different ways. You can have medications that exacerbate underlying sleep disorders. You can have medications that make people sleepy during the day so they can't sleep at night, or that are activating at night so that they can't sleep. So medications can affect sleep in a lot of ways. And then finally, sleep disorders. Almost every one of these becomes more common as we age. And so here are sort of all of the reasons why we think these people are more likely to have insomnia. So I wanted to show you a little bit about this cohort. So first of all, an older age group, right? Average age of 84. And then you can see also these are people with a lot of medical problems, cardiovascular disease, lung disease. So these, a lot of comorbidity here and a lot of medications, on average, 9 prescription medications. And then you can see high rates of depression, cognitive impairment, and low physical activity. So we think this is really a cohort that is just, that has so many reasons to have insomnia. And so here's what we found. Briefly, insomnia was common, but severity was mild. And so here I'm showing you the different results. And so if we think about that threshold before that I showed you of 8 and above, then we can say that the prevalence of insomnia in this community dwelling group was 43%. And if we look at the average ISI score among that group, we can see that it was 12, which is very much in that mild category of insomnia. We did look at adjusted risk of worsening insomnia over time. As I said, we wanted to look at age specifically. And when we compared these age groups to the younger age group, we saw no worsening of insomnia severity over time. And then we looked at other factors, and we did find that certain things were associated with increasing risk of insomnia over time. Our sleep disorders, restless leg syndrome, sleep apnea, depressive symptoms, the number of medications. So this was the increased risk per medication, and actually having daytime hypersomnia. If we look though specifically at the ISI scores, we saw no difference in mean ISI scores over time in the different age groups. So we have here the black is the youngest age group, red is the middle age group, and then blue is the oldest age group. And what you can see is if we look at their ISI scores over time, they're virtually overlapping. And they're also really below that threshold of 8. So they're really, the average scores are falling in the normal range. So insomnia was common. It was multifactorial. I showed you all of the things that were associated with worsening insomnia over time, but severity was mild. And we saw that ISI scores did not change over time or with advancing age. So this was a surprising result for us. Let's see this. I'll get to that question in a second. This was a surprising result for us because, we just thought this cohort has so many risk factors for having insomnia. So I see, are there differences in risks for decreased sleep quality with aging in terms of those who have typically been late nighters for most of youth, middle age versus early to bed historically? So, I think what you're trying to get at is, are people more predisposed to have, you're using the term sleep quality, poor sleep quality because of their circadian phase. And if I'm being honest, I don't know the answer to that question. What I think is really interesting is that in an older population where they may have more flexibility in their sleep-wake schedule, they're more able to sleep at the times they would like, right? So if they're advanced, they can go to bed at 7:30, no problem. If they're delayed, they can go to bed at 2 o'clock in the morning and wake up at 10 or 11, and that doesn't create a problem. So it tends to create more problems for a younger age group. But I welcome anybody else in the audience who knows more specific links between those between sleep quality and circadian phase. I'll tell you also briefly about a similar study we did this time looking at hypersomnia, which is severe daytime sleepiness or long sleep time at night. And then this was again with that same cohort, the PEP cohort. And we thought for the same reasons that hypersomnia would be prevalent and severe in this group because they have all of these risk factors for having daytime sleepiness. And we found that hypersomnia was multifactorial in this group. So it was worse in people with low physical activity. It was also associated with depression, or sleep disorders, again, restless leg syndrome, sleep apnea. It was worse in people who had more severe insomnia and in people who were on CNS depressants. So that was skeletal muscle relaxants, anticonvulsants, and narcotics. Well, we saw here a similar pattern in that hypersomnia was common, but that severity was mild. And so the median Epworth score overall in the cohort was 6, which is, again, 10 and below is thought to be in the normal range. And then if we look at that, use that threshold of 10 to look at prevalence of hypersomnia, we saw that it was prevalent in 23% of the cohort. But that, again, most people were in that mild range. So this got us to thinking, are existing self-reported sleep measures appropriate for older adults? And what might be some mechanisms for discordance between self-reported and objective sleep? Well, perhaps symptoms are better tolerated. They've been living with these symptoms for a long time, so perhaps they're less likely to be bothered by them or report them. Is this lifestyle mediated? Again, they have flexibility in their sleep-wake scheduling. They may not have the same daytime demands because they are retired or they don't have significant caregiver responsibilities. So if they are not able to sleep well, perhaps it's not as bothersome. There is the paradox of well-being, which is really this phenomenon of saying, well, here I am, I'm 85 and I don't sleep well, but my sleep's not as bad as I thought it would be, right? So because of that, because people are doing better than they thought they would, perhaps they're less likely to report a problem. And then I would also mention the validity of existing measures. Many of these were validated in younger people. And so I'll pull out a couple examples here, right? The Insomnia Severity Index asks how worried people are or how much their sleep is interfering with daily functioning. Those questions may not be so meaningful to an older population that is retired and has less daytime demands. And then in the Epworth, I see this all the time in my clinic. I have people who don't drive anymore, or they have low vision, so they don't read or watch TV. So perhaps these questions are not as meaningful to an older population either. And then I also wanted to bring up this idea of blunted awareness of symptoms. I mentioned this in the case in this woman with a lot of psychoactive medications. Did that blunt her awareness of her symptoms? The fact is we are seeing this growing literature to suggest that this may be a phenomenon in older people. Older people have milder respiratory symptoms in response to bronchoconstriction, less severe symptoms in response to hypoglycemia, and higher rates of silent myocardial ischemia. And actually, we know from previously published work in sleep that older people may have more severe sleep disorders, but actually report milder insomnia, hypersomnia, and fatigue. So why does this matter? For those of you who aren't familiar, this is the shrug emoji, and these are my daughters doing their best impression of the shrug emoji. Why does this matter? Well, I would say we may be missing diagnoses, and that's a missed opportunity, right? Because we know that these sleep problems are associated with many adverse outcomes. And so it's possible, if we're better at detecting them, we can reduce the risk of adverse outcomes. And the other thing I would say is we may be inappropriately evaluating our interventions. And the example I like to use here is the LIFE study, which was this very large multi-center trial of a physical activity intervention to decrease disability. And the LIFE study looked at sleep as a secondary outcome and found in those people who got the physical activity intervention, there was no difference in terms of their report of insomnia severity or daytime sleepiness. Now, is that because physical activity has no effect on sleep? Or is it because we are not using the proper tools to evaluate our interventions? So I'll take you through just, I think I have two more projects that I'll present quickly. And so the first one is looking at this next domain, insufficient sleep duration. And in this project, we compared self-reported and objective short sleep. And so short sleep, I'm defining here, is less than or equal to 6 hours, because we know that that sleep duration has been associated with many adverse health outcomes. So here I'm showing you a well-known U-shaped association between sleep duration. In this case, I'm showing you mortality, but I could show you, many other outcomes where we see the same U-shaped association. And so what you can see is once we get to 6 hours or less, the relative risk of mortality is increased. I'm not going to talk about this today, long sleep duration, but you can see also for people with sleep duration on the other end of the spectrum, very long sleep duration, their mortality is also increased. So we use this, this literature to define short sleep. And what we wanted to do was to first describe the prevalence of short sleep duration in an older population, and to evaluate the diagnostic accuracy of self-reported versus objective measures. Again, because we're wondering, is there this discordance between how older adults report their sleep and how they're actually sleeping? And so this study we did using publicly available data from the study of osteoporotic fractures and this companion study in men, which is the osteoporotic fractures in men sleep study. So these were large cohort-based studies you can see of an older age group, and they were really designed to look at different risk factors and sort of resilient factors associated with aging. And because of that, each one of these had dedicated sleep evaluations. And so in those comprehensive sleep visits, we looked at self-report versus objective measures. And in this particular study, the objective measure is going to be coming from actigraphy that I discussed before. So we found poor agreement between self-reported and actigraphic short sleep. So I'm starting here with Mr. Oss, the men. We have self-report over here, and then we have our sort of reference standard, which is actigraphy here. And so I'm showing you something you all probably are familiar with, which is this 2x2 table. And so what I want to focus on are these blue quadrants, which are the discordant quadrants, right? So we might think of this over here, people self-reporting short sleep, but not having it according to actigraphy. That's maybe our false positive. Down here, we have our false negative. So you can see in men, those discordant groups were pretty common. And in women, similarly, those discordant groups were common. And so when we calculated the sensitivity and specificity, what we found is the sensitivity of self-report to detect, what we consider the reference standard here, actigraphic short sleep was quite poor. False negative rates were 51% in men and 43% in women. The specificity was a bit better, but still not that great with high false positive rates. So, false negatives, again, I think of that as a missed opportunity, but false positives are problematic too, because perhaps in these cases, we're doing things like using hypnotics inappropriately and exposing people to risk. So this is the final study that I want to present today, which was looking at insomnia with objective short sleep duration. So really, trying to think about sleep in a more comprehensive way by really evaluating sleep across these different domains. So insomnia with objective short sleep duration is something that has been studied in younger and middle age groups, and it's known to be a high-risk phenotype because these people have been shown to have an elevated risk of cardiovascular disease, diabetes and mortality, and even cognitive performance impairments. And there is literature to suggest that cognitive behavioral therapy for insomnia, which is sort of our gold standard way to treat insomnia, may be less effective in this group. But we don't know as much about this phenotype in older adults. So again, using data from the Mr. Oss sleep study and the study of osteoporotic fractures, we looked at the prevalence of insomnia with objective short sleep. We found it's quite prevalent, right? So 21% of men and 13% of women. And at the risk of giving you way too much to digest, but I'll just give you a sort of snapshot of this work that's under review. I want to show you associations between predisposing, precipitating, and perpetuating factors and this phenotype, insomnia with short sleep duration. And so I'm going to show you these models where we have adjusted for age, race, ethnicity, education, obesity, and multiple chronic conditions. And so here is what we found in men. How is insomnia defined, disorder or symptoms? I'm not surprised you asked that question. And again, I'm sorry that I'm trying to cram all of this stuff into a short talk, but insomnia here was based on the sort of, the standard insomnia symptoms. So difficulty initiating sleep, difficulty maintaining sleep or early morning awakening. And then the short sleep, the objective short sleep here was defined by actigraphy. Previous literature has used polysomnography to do this. And, as I sort of alluded to when I was telling people about the different tools, I think there's some problems with using polysomnography in this group. Both because it's cumbersome, but because you're also not studying people in their home environment and you're only getting one night of sleep. So I think that's the value of actigraphy here, although it has drawbacks. And predisposing factors are really, these are increasing vulnerability for insomnia, but not themselves causal. And so, here are the different factors that we looked at. And again, in a sort of minimally adjusted model in men, we can see that older age, obesity, and having multiple chronic conditions were associated with higher odds of having insomnia with short sleep. Predisposing factors are really, factors that can be in and of themselves directly causal to insomnia. So here we're looking at mood disorders and medication use, and you can see that these also increase the odds of having insomnia with short sleep. And then finally, perpetuating factors. So, napping, I think, is a sort of common perpetuating factor. We think these are factors that allow insomnia to continue even after predisposing factors have resolved. And so, here I'm looking at napping, which is sort of a common behavior that we might target with insomnia treatment, but also thinking about these geriatric conditions, physical impairment, falls, and frailty. Again, I think of them as perpetuating factors because they may lead to behaviors that aren't themselves causal to insomnia, but may perpetuate insomnia. And so we can see napping and falls in men. I'll get to the question in a minute. I'll just show you what we saw in the women, which was similar. So we saw, these predisposing factors, obesity and multiple chronic conditions. We see, predisposing, I realize I mislabeled these. So this should say predisposing, this should say precipitating and perpetuating. So sorry, precipitating factors thought to be, potentially directly causal to insomnia. So we see a lot of these associated with increased odds of insomnia and short sleep in women. And then we see both the napping and also these geriatric conditions. So, just to finish up quickly with this slide, I'll say we have the kind of more comprehensive evaluation of sleep when we're looking at insomnia with objective short sleep duration. And we can see this is probably a very high risk phenotype in older people. It's associated with a high comorbidity burden. It's associated with a lot of geriatric syndromes. And so what I'd like to do going forward is to use this work to, this is all cross-sectional. But I think we can use this work to really try and define insomnia in an older population and really to define risk factors, which may become modifiable factors in future interventions. So the questions I see, did the sleeping hours in your study include both daytime and nighttime sleep time? Briefly, no. This was just looking at overnight sleep duration. I see your point and it's well taken. I think it's just very hard to measure daytime sleep objectively. So I know, certainly people are looking at actigraphy to try and look at nap time behavior, which is problematic. But in this particular study, we are just using the actigraphy-based overnight sleep duration. And then the next question I see was the fall measured as a history of falls versus fall risk. So this was self-reported by the study participants having at least 2 falls in the past year. Okay, so I'll finish up with future directions, which is, what I hope to do and work of my current K award, which is to evaluate this more comprehensive idea of sleep deficiency in older people. And so what I'm doing now in my K, this is sort of the first aim is a quantitative aim where I'm examining objective measures of sleep deficiency. So I'm doing polysomnography, but it's in the home. I'm comparing it to this sleep measuring headband, which can do EEG, and I'm also using actigraphy. In the next part will be a qualitative phase where we explore perceptions of sleep deficiency. Again, trying to get at that idea that perhaps we need to ask more relevant questions for an older population. So hopefully with those things, we can integrate into aim 3, which will be to develop and pilot test a new sleep deficiency instrument that's sort of specifically designed to evaluate sleep in older people. So that's the work that I'm doing now. This is the headband, and this is my sleep histogram after wearing the headband. And so, I'm going to see if this is a feasible option in older people, because, as I alluded to, I think we need better tools. So I'll finish with some key points. I hope that I've shown you that sleep is important for health, quality of life, and independence. Always ask about sleep. Sometimes for various reasons, your patients may not bring it up. And I would say, especially with psychiatric disease, cognitive problems or functional decline. Be specific when eliciting sleep patterns and daytime consequences. Think about when are you going to bed, when are you getting out of bed for good, but also seeking collateral information. And I would say, my feeling based on my research is that we need better tools to evaluate sleep in older adults. And so that's what I'm working on. I have to bring this up because I think most people come to this talk and they want to know about treatment. And I think there's just no easy answer here. I would say start with a thorough history and workup. When people come to me with a sleep problem, they often haven't had this. and try to identify those important domains. You know, are they on a medication that you could fix? Do they have an undiagnosed sleep disorder? So that's the best that I have. There's no easy answer. I will finish now by just acknowledging my funding from the NIA, from our Pepper Center, you know, that funded me at a time when nobody else would. So I wouldn't be here today without all the support of Yale's Pepper Center and the amazing investigators that I get to work with. So I want to thank Terry, our section chief, Tom, Mary, and Carlos, who've been so instrumental in helping me move this work forward. My collaborators in pulmonary critical care and sleep medicine, and my statistician that I work closely with, Margaret Doyle. So that's it. And I'm happy to take any additional questions. And I see a question here. I see a dementia population, so I ask the Epworth questions first to the patient and then to the caregiver, for example, the family member. Yeah, so I actually do something pretty similar. I make sure to ask about napping also, because the Epworth doesn't ask about napping. And I find that can be, you know, because of all those reasons that the Epworth doesn't work in this population, napping can be very telling. And it's oftentimes, you know, the patient says, yeah, like maybe I nap a couple times a week, and then you talk to the family and they're like, they're falling asleep all day long, right? So I find that's a useful way to ask about daytime sleepiness. Is there a link for, oh, sorry, that's not a question for me. Anybody else who has a question, please?
Does anyone have a question for Dr. Miner?
Sure.
Feel free to speak up or raise your hand in the Zoom. I think you answered some questions as you went along, and so we do appreciate that. But thank you for such a great talk. Really wonderful.
Thank you. I'm glad you enjoyed it. It's hard on Zoom because I can't see you guys, and I don't know if any of this is registering, but hopefully it was somewhat.
I think it's very relevant, and clearly we're going to need to have you come back in a few years and give us an update on all you've been doing.
Hopefully,
so,
yes. Hopefully I have some answers.
That's great. All right. Thank you. And thank you everyone for joining us. We'll see you again next month.
All right. Thank you.
All right. Take care. Thank you.